So everybody will have 10 minutes, and we will assume that you will keep to those 10 minutes because we would like to finish somewhat close to time so we can have, we have the buses coming, so we can have dinner. Let's begin with the research group, and whoever was the individual who reported out from the research group. Here we go.
For the research group, somewhat reluctantly. We actually met outside. We all got vitamin D. I don't know what's wrong with you, but our bones are feeling strong. Please, anyone in the group, chime in and redirect me when I stray too far from what we actually talked about. But there was a fair amount of discussion about the need to break away from the silos that have existed primarily dominating these fields, and we can, really get some important work done together. In a way, this might be borne out because of how poorly funded some of these things have been for research. One of the problems, it seems, is that really there's not a really good home at NIH or at other places federally to fund research on LEP stuff, and you'd imagine that could have a home, say, in AHRQ, but that really hasn't been pulling its own weight in this research arena. So one of the strong claims that I would like to I'd like to make sure that somehow gets put forward is, if you want this flower to grow, it's going to have to get watered. It needs to have...
Not in California.
Well, maybe in D.C. So, adequate funding is really going to be needed. Now, the actual ideas for how we could advance a common research agenda for LLC really did span a pretty broad array of concepts. We did spend a fair amount of time focusing on communication, but also on systems, and ranging all the way from the health outcomes type work to business case kind of conversation. And it's not going to be surprising that all these themes came out. Did anybody want to mention any other themes that were important in our... Yeah? So I'm going to now purvey the balance of my time to the esteemed senator from Boston. And thank you very much.
You're coming back, Michael. You're coming back. We did talk about the fact that there needs to be more research, clearly, that supports the value argument. We talked about the fact that we do have data available for us. We do have, really, the questions are already there. But the quality of the data collection process, and the analysis that uses or does not use the available metrics really needs to be improved. So it has to do with rigor of research, because an awful lot of what we want to do is there waiting for us. We did talk about the fact that there is intervention research when there are interventions, but they are few and far between, and we don't have enough research that informs the design and development of the intervention itself. We talked a great deal about the need to look at concordance, but within the context, the larger context, of the different attributes and qualities of a system. We talked about the need to make sure that we measure at minimum both sides of the coin and whoever's tossing that coin, meaning that we can't measure anything anymore about patients without knowing what it is that the provider is doing and the measurements of the quality of that interaction and the context within that interaction is taking place. So we really did do a little bit more about the specifics of research.
Yeah, just a few additional points. I think there was a general shock with how poor with collection has been in some ways. We saw the slide from NQA, that maybe a quarter to a third of reporting hospitals reporting on basic measures. I mean, we're talking about over a decade now when people have been talking about, oh, you're going to need to report in race and ethnicity. And by the way, another theme is that the way we collect that data is anyway really, really gross, if not to the point of offensive, categorizing people in these massive buckets and making some of the analyses that you can do out of them rather crude, even if you could do them at all. And obviously, if you only have 25, 30% of the hospitals reporting their data to NQF, then you're missing a lot, and you probably have a lot of garbage data in there anyway. So improving the sources of data would also be quite useful.
Thank you very much. And we will go to the research group. Michael? I mean the policy group. Michael?
So for the policy group, we in fact met indoors and did not get our dose of vitamin D. But we had a rather wide-ranging discussion, some of which focused directly on policy, some of which was just very interesting discussion. And I, too, like Michael, was a rather unwilling recipient of the rapporteur role here, but I will take the challenge and move forward. So essentially, in the policy group, we talked about a number of different policies and areas in which some of these efforts have been put forward, and the relative success or challenge of some of those. I think in general, one of the takeaway messages was that boldness and leadership plays a very, very strong role in this particular area. When the example was given of LIJ, and that was a great example of integrating a lot of these types of programs to reduce disparities, encourage inclusion into a larger organization. And when the question was asked about what was the motivating factor for that, was it the carrot or was it the stick? That essentially it was the carrot. This was the right thing to do. You can't really put policies in. The notion of an unfunded mandate came up quite often. It's difficult, if not impossible, to put out a mandate for which there is no funding and expect there to be complete compliance with that. So the areas I think in which there's going to be a lot of movement and a lot of traction are going to be those ones put forward by the visionaries, by the leaders, the ones who have the great ideas. The phrase that was in there is that the policies are for the followers, not for the leaders. The leaders are the ones who initiate these things on their own. So we talked about NCQA a little bit and the differences between their standard accreditation policies and the MHD ones, and why can't those be made a little more equal, and cost, frankly, is one of those issues. There was some discussion about ways in which we can engage with those groups who are most affected by health disparities and health inequities, and how can we learn from their experiences to provide the service, the care that is going to meet their needs a little more effectively, and ways in which we can do that. And there was a couple of examples that were given of that. In Massachusetts, they have listening sessions where individuals come up and discuss some of their concerns and things that they would like to have done. Sometimes policy is made out of that. Sometimes it's not made out of that. So although it is a great opportunity, it's not a guarantee that change will be made at a policy level. Similarly, in Arkansas, patient advisory committees have been submitted, and so that's another opportunity for us to intersect with these affected populations, and just other opportunities. So part of the policy was, in the policy discussion, was to try to identify additional ways that we can submit changes or tweaks to existing regulations to help incentivize practitioners to implement some of these changes. I think ultimately, in the end, we really said that we need more voices from the populations that are affected. There's different ways to do that, but ultimately, I think what we're really talking about is that we are looking for bold solutions, and probably, to put it in a different perspective. We've been using a transactional approach by tinkering with things. This really probably needs to be more of a transformational effort where we say, we just need to acknowledge that this is the elephant in the room and that this is an untenable situation and that we need to make system changes, let those leaders come out front, leader-to-leader discussions. Let's talk directly with the head of CMS and say, these are the changes that need to happen, and let's talk about ways in which we can implement them. Other folks from the group who can save me as I'm dying out here.
You did a very good job, Michael.
Thank you.
Thank you. The Services and Care Group. Oh, here we go.
Here. And just for my own sanity, let it be noted for the record that I was a volunteer replacement moderator who is now a volunteer replacement report back person. I'm going to change my name.
To what?
Volunteer replacement. So, and really everybody just jump in here on this because we had a sort of wide-ranging and quick conversation about a lot of things. And we tried to ignore Lila's time limit, but we failed. So we really started with, health literacy has come a long way, especially in regards to shifting of the power in the sense of what health literacy is. But at the same time, we all universally agreed that it was essentially in its infancy still, especially in regards to integrating across language access, cultural competency, and health literacy in effective ways to reach patient outcomes. That integration was still lacking. And we tried several different terms of how to sum that up, but I frankly don't think that we hit upon one that everybody was really agreeable upon. So I think just know there's a need for some language there that we aren't filling for people really very well. There was a point which agrees with many of you, even though many of us didn't agree with all of it, but what gets measured gets managed. It was certainly a theme throughout the day. How you do that, of course, became a critical issue, a critical question. And people talked about the difference by directionality. Where do you measure? Who do you measure? That it's a dynamic state, et cetera. I think you've all heard this before. Just know that it came up, was discussed, remains an issue, but we weren't the research group, so we decided not to solve that. And we made the point that collectively they're in the infancy, but also in the individual, right? Health literacy is in its infancy in so many ways. Language access is, Wilma, thank you for pointing this out and for finally getting up here on a panel. It's about time. That language access is also in its infancy, and I think we sort of implicitly agreed that that's true for cultural competence, or whatever word you want to put after culture in that respect as well. Lots of agreement. Health literacy is more than communication, goes to navigation. There's a strong skill set. There's also an unconscious bias. We had a nice discussion about two aspects of cultural competency that I fear I'm not going to get right, so people please jump in here, right? One, cultural competency and other terms are also used as a surrogate marker for race and racism and ethnicity without the proper discussion and frankness of that discussion. What happens in communities every day in this regard doesn't happen in the halls of academics or Institute of Medicine roundtable meetings a lot. We use words as surrogates a lot. At the same time, pause for commercial break. At the same time, it's not there. I'll just have to do it out of memory. Lori Martin, no, it's all right. Is it? This includes different states. Yes, that's it. You're right. I take it back. So while there is much diversity in our training, that whole approach, the core issue needs to be elevated so as to decompress the privilege of cultural competency and that words as an approach to a real solution, a real problem in real people's lives, that what we're doing today is not sufficient. So one, we're cloaking it in other language. Two, what we're doing isn't sufficient. Is that about right? Okay, thank you. So then we tried to move to potential solutions, because why be so pessimistic all the time? The nesting doll metaphor didn't work for people. at the end of the day. We couldn't come to a conclusion on what nested what. So just, we talked about it. It didn't really come to an end. A lot of people agreed on the notion of talking with someone versus talking to someone. We then, what are the outcomes of that, and went through the conversation many of you have heard for years, appropriate versus informed, and what does that mean, appropriate to who? Right? If it's appropriate to the patient, is that a valid outcome? If it's appropriate to the health system, is that then an invalid outcome? And what does an informed decision really mean, especially if they say no to what the healthcare system thinks is quote unquote appropriate? How do you balance those out? Effective bidirectional communication was one of the phrases that we threw out to try to say this is the master rubric of the area. But again, I don't think anybody would say that we came upon a real answer there. The clear possibility of a lot of low-hanging fruit was brought up, so then we just tried to real quickly identify some of them. There was a lot of agreement around time, right? What do you want to change? You want to change the amount of time that people have to spend with a healthcare professional, or maybe I would say you would like to change the amount of time healthcare professionals get to spend with people. And I promised you I was only going to moderate, but this is a short conservative side trip. I personally am on a path to ban the word patient. It's a person. They're people. And you don't need to be patient to be a patient. You can just be a person. That's a small change, but we could do it. Whereas somebody suggested blowing up the entire system and providing rational enlightenment, which is not a bad thought in some respects. Honoring all people, asking them what's important to them. Another solution, examine our policies, get lots of input. So input and engagement were consistent themes. Time was a consistent theme. And then make changes, and then evaluate them and see if they worked. And if they didn't work, make changes again. It does not have to be a one-off deal. And finally, looking at accreditation across the range of health services and health professionals, and seeing where these three key issues, health literacy, cultural competency, and language access are and are not adequately represented now, and change those. And I think that's about it. But I might have left something else. What do you guys say? Done?
Okay, we have adequate time for discussion, and hopefully some of the ideas generated will lead to good discussion. So I'll open it up to the floor for comments, discussion, questions. Chris? Yes, you can.
I guess this is a question for Michael or the research group. Oh, sure, Chris Desi, Bristol Myers Squibb, part of the roundtable. For the research group, did the concept of relevant outcomes was, how do you identify, or could a health literate person be identified as an outcome? In other words, if you do everything you need to do with me, and I get to the point where, I got it, is that something you can codify? So I guess my question is health literacy an outcome here? I think somebody mentioned that on one of the panels earlier. Because I'm seeing a lot of these, the cultural competency activities and stuff are all to get to a place of patient understanding and this concept of bidirectional input. So I guess I'd like if anybody on the research side was thinking of that. Thank you. So we'll start with Michael.
Well, this is not an answer to this question, but just to mention that there is a group, a subcommittee of this group, working on what we're calling, for better or worse, the definitions paper. It's a perspective paper about definitions, and one of the issues that's being discussed, and we'll see how it plays out, is about what's the nature of the outcomes, and what's the kind of, is that built into the nature of the definition or not? And so, we're still trying to figure out if there's consensus on some of these matters. But it's I would say, a fair topic to, something we should be talking about. And I don't think I can like characterize that exactly, but you know, this gets into, you know, more broadly speaking, what's the definition of health literacy anyway, and probably not something we can decide before dinner. At least before dinner. After dinner will be fine.
Yes, you can. So just identify yourself to the microphone.
Actually, this issue did
Can
come
you
up.
just identify
Oh,
yourself to
I'm
the...
sorry. I'm so sorry. I'm Janet O'Henny from Pung, independent consultant in the field of health communication and cross-cultural communication. All right. This came up in our group, specifically, actually, because of the question that you asked. And there was a feeling that really maybe what we should be thinking about is not really measuring, you know, health literacy outcomes in that way, but actually health outcomes. And to take the focus a little bit off of the person, not patient, and put it really more on the provider. That if providers are effective in the way they communicate with people across fundamental literacy levels, across, you know, health literacy levels, different in the sense that it's a broader issue, across languages, because languages is a no-brainer, obviously, if you can't speak the language and you're not communicating well, and then also across diverse perspectives, which we refer to, I mean, there's culture, but how people see things differently. Then what you're looking for is, you know, their hypertension is getting better. They're managing their diabetes, you know, more effectively. All of these are things that actually, that's what you can actually measure. So it did come up as an issue, and it came up specifically because of the question that you asked.
I'm Jennifer Dillahay. I'm with the Arkansas Department of Health. And through all of these report outs, I can't help but think what a key leadership is in each of those areas. And so I'm thinking to myself, well, what can we do as a roundtable to promote health literacy leadership? So we saw a really good example of a health system with good leadership that made a lot of systems changes that perhaps policy wasn't necessary, or perhaps they established the policy rather than policy being mandated to them. And then I started thinking about a couple of references we made earlier, you know, because health literacy is from my point of view, a skill set that is used outside the health system. And it's closely linked to social determinants of health. So we also need health literacy in policymakers for things like food deserts, complete streets, and so forth, because we need policymakers who can understand, and use health-related information to make decisions, not just for their own health, but for their constituents or the people that they are responsible for. So there's a really broad continuum, and I guess we need to work on that with the policy or the definition piece. But for all of this, to me, comes back to a leadership issue. And what do we do to stoke that or communicate that or ignite it? So that's my question. What can we do?
A leadership issue on what level would you suggest?
Well, I think it's a leadership issue on multiple levels. I mean, you can have people such as myself who operate in a state, and I try to influence people what I have influence over. And that can have a ripple effect. But there can also be a leadership issue, like the head of a health system that has an organizational, functional leadership issue. And then you can have people who are visionary that can have leadership in terms of a community. So it can be multiple levels.
Michael?
Actually, I think it might be fun to pursue this theme, and maybe to pose the question. There have been efforts at different times to create health literacy initiatives at the state levels. And so for people who have been doing that, working at state level initiatives, anybody have experience with developing leadership at the state level to inform policy on health in the state? So there's several people here who do stuff like that. I don't know if you could share, because one of the things that could come out of having more states get involved in that level would be development of policymakers to know more about health and to be involved in various ways.
So, Katina O'Leary, Health Literacy Missouri. So we're one of the groups of people, I think, that do the work at the state level fairly broadly in Missouri, at least. And so not government, but a separate freestanding nonprofit organization. And I think Jennifer's point about kind of multiple levels of leadership is really important here because you know, we have support from the highest levels of leadership in the state that say this is really important, do this, change the forms, change the process, change the work, and yet kind of trickles down, and sometimes it happens and sometimes it doesn't, because every policy is kind of dictated by the people who put their hands on it and actually make things go forward or not. So this kind of broad-based partnership and development and relationship and talking about it, kind of beating the drum over and over, has been really important to us. So very specifically, we have a contract with the state of Missouri to do pretty extensive work on forms and processes and working with advocates and doing all this stuff around the Medicaid forms. And it's, you know, 18 months of work, and it's all about the people who sit in the offices at the Department of Health and Human Services and what forms they say are problematic or not. And then the people at the print shop who print the forms and what they allow to happen or not. So multiple levels of people who are interested and empowered and want to make that happen, which is maybe really different than what we were thinking about when we were talking policy before and we said call the head of CMS, which is also an important strategy. So I think what I would say to that is wherever you are, whatever you can do over and over again until it happens. Fair?
Jessie Sherrod, a former Robert Wood Johnson clinical scholar. I'm just a guest here. But I sat in on the research and as well as the policy group. And I'm thinking that there are so many variables that affect health that we need, I think, leadership from the top, where there's a broad policy where every area is impact and is conscious of health when they are making policy in the United States. Now, maybe that's a little bit far-fetched, but I think that is one way of getting to the root of the problem in every category, because the environment, the environmental policies, the food, the nutritional policies, all of those kind of things, as well as literacy, language, and all of that affects literacy. Health literacy, affect health is what I'm trying to say. So I'm thinking that something at the Surgeon General level, it was mentioned in the policy group, where you take a broad brush and look at or make everybody, just raise the level of consciousness about health when you're making policy.
So I like that suggestion about the Surgeon General that came from the policy group. I think that here is an opportunity to take bold initiative, and just as they did with the smoking issue a number of years ago, this could replace smoking, and as a national initiative that really would make a difference, specifically if we look at the demographics of this country going forward. I would suggest that we as a group seriously consider doing something like that as, I would say, a bold initiative. So perhaps somebody will bring this up at tomorrow's discussion, and Lila will carefully note that that is something perhaps that we could move on. And I would be happy to make the introduction. It's not necessary to put your jacket on.
Thank you. I feel a little underdressed without it, but I appreciate the goodwill. I'm struggling a little bit with the conversation this afternoon, and I think it's because of the slide that our colleague from NCQA, is she still here? Our colleague from NCQA showed. That was an amazing slide, that NCQA is having trouble getting commercial plans to collect and report out data on race, ethnicity, and language. Should give us pause. I have not seen that data. I don't know if it's been published. I assume it's certainly not secret. And it is extraordinarily telling, because it means that we've been saying the same thing for 15, 20 years, the thing that everyone agreed on. We need data, and yet it's not working. Be it because we call it an unfunded mandate, or be it because we call it imposition from, I don't know, above or below or the side, it's not working. And so I do think that the two things that I'm taking away from today are that slide, and then the very interesting conversation about how to frame this question within a business case versus an ROI case versus a value case versus an equity case versus part of a patient safety initiative versus all of the above or none. And I think that is the other debate that we need to have. But I would feel much better if if it were possible, and perhaps it's a discussion for another day, to think about where the IOM and other organizations can move boldly. And I think it would be good to talk about what those levers might be and what would be appropriate to push. So I'm sorry I don't really have a question, but it's more just if people are feeling more optimism than I am, I would like, that would be good too, to hear as well. So thank you.